Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So on this episode, I'm having a conversation with Jaryd Bourke. Jaryd's a podiatrist and a PhD student in the Department of Physiotherapy at Monash University, and he has a special interest in the management of Achilles tendinopathy, which we'll talk about today. So his PhD is investigating the effects of different heel lifts and height and density, for example, on patient outcomes in people with Achilles tendinopathy. So we're back to a musculoskeletal topic after the last two episodes, but promise I'll try to vary things up for you in the future as well. Jaryd has a background and interest in strength and conditioning and working in private practice. So Jaryd's originally from the town of Wodonga in country New South Wales, about a third of the way between Melbourne and Brisbane. And he completed his podiatry studies at Charles Sturt University in Albury. And after graduating in 2019, he moved to Hobart, Tasmania, where he works as a podiatrist at Leap Health. And since 2021, so 4 years ago now, Jaryd's been working on his PhD with our group, supervised by Professor Peter Maliaris and team. And this is going to be the main focus of today's conversation. We're going to talk about the findings of his PhD so far, the ones we can talk about that are published. And I'm also interested in general in the role of podiatry in the management of Achilles tendinopathy and other conditions. So we'll see what comes out of the conversation. Let's get the party started. Jaryd Bourke, welcome to Physio Foundations.
Hey, Luke. Thanks for having me.
Good to have you on. Anything I missed in the background and the biography there, your background and interests and career so far?
No, that's a great summary. I did spend a little bit of time in Melbourne in between my stints in Hobart, but that was just for data collection and the study.
Yeah, and that'll come up as we talk. So before we talk about your PhD work and the findings so far, let's talk about the condition of Achilles tendinopathy. So let's go back a step. What is tendinopathy? And then we can talk about what is Achilles tendinopathy.
Yeah, tendinopathy is any pain with use that isn't associated with tissue damage. And it's commonly stiff in the morning, eases with movement, and very, very common in athletes and people who do lots of sport.
Yeah, good general summary. So what about Achilles tendinopathy? Obviously, lots of force goes through the Achilles. Lots of research has been done in this area, and it's a common and burdensome condition. Tell us a bit more about Achilles tendinopathy.
Yeah, definitely. Achilles tendinopathy is, the Achilles tendon attaches the calf muscle to the back of the heel. It is used mostly while walking and running, and it from some biomechanical studies, you can load it up to about 10 times your body weight. So huge amounts of force, and it can be prone to one of the most commonly tendons prone to tendinopathy. There's two types: insertional, which is the back of the heel, and mid portion, which is a bit higher up, about 2 to 6 centimeters from the base of the heel. And it's the similar risk factors and presentations, but they're different injuries with different treatments.
So that's why you've focused on one rather than mixing them together, and you're focusing on mid-portion Achilles tendinopathy. What if we segue to your role as a podiatrist? It's the Physio Foundations podcast, but we're learning from you today as a podiatrist. How do podiatrists help people with tendinopathies, particularly Achilles tendinopathy?
Yeah, well, podiatrists can diagnose Achilles tendinopathy and mostly offer shoe inserts or shoe-related treatments like orthotics and heel lifts, and to a lesser extent, exercise prescription.
Yeah. And how would you work with physiotherapists if the same person was seeing you and a physio in your clinic, for example?
Yeah, definitely. Well, the physio may take on the strength and conditioning and any manual therapy, and then the podiatrist may offer heel lifts, footwear advice, orthotics, depending on the person.
Yeah, and you have some shared goals as well, and loss of communication in between you. So I guess that's a good segue into your research, which was looking at those heel lifts. So bearing in mind that we can't talk about some of it's to be presented at upcoming conferences and published in peer-reviewed journals. Let's take a step back and talk about your PhD, what you have found so far, what's been published, and talk to us about the research in this area.
Yeah, definitely. Well, anecdotally, heel lifts are used all the time for Achilles tendinopathy, but there's very, very, very little research on whether or not they're effective. We published a systematic review, and there's been to date 2 studies on heel lifts and Achilles tendinopathy, and particularly mid-portion Achilles tendinopathy. And there is signs that they work. The most popular study is Chantal Rebuson's from La Trobe, where she compared heel lifts to exercise and found similar effectiveness. And considering that exercise is the gold standard treatment, it was a promising sign.
So I think you've hit the nail on the head in that you've got a low-cost intervention that's commonly used, and yet we have a small amount of evidence for it. So that leads you into your PhD with doing a thorough investigation of it. Just to throw this one at you, what's the clinical rationale for using a heel lift, regardless of whether you're a podiatrist or a physio? So it's the person's main complaint is pain, and you're putting a heel lift in for less load. You mentioned 10 times body weight through the Achilles tendon earlier. So there's a lot of load reduction that you can achieve by putting a heel raise in. What are some of the other thoughts that go through your head as you perhaps for a short-term intervention, use a heel raise? What's it changing?
Yeah, the main use of heel lift is to plantar flex the foot or point the toes down. And the idea is to shorten the tendon to lessen the load on it. As the tendon stretches, it goes through a quite significant load, as we talked about. And any ways to reduce that load, we theorize, will just be positive on pain. Especially because when patients come into clinic, the things that tend to be the trigger for their pain is activity, and it typically ascends as that intensity increases, like sprinting, jumping, and then running. So
heel lift, and I was calling it a heel raise before, so let's call it a heel lift, reducing force, reducing pain, allowing the person to continue physical activity, which is important because then you can exercise and continue on with things. How long do you typically, as a clinician, leave a heel lift in for?
It really depends. Most people about 12 weeks, but
okay.
As we know, this injury can be long lasting, particularly in elite long distance runners. So it may just be something they use to keep training and reach their goals. It's difficult to say because some people will have this condition for a long time, many years.
Yeah, so it does vary between people a lot, doesn't it? I'm thinking of zero drop shoes now, which were a big trend 10, 15 years ago. I still run around in a pair of them myself, but I find them really helpful. It's very individual though. I've also got a big 12 mil stack on another brand of shoe that I use on different days. Sometimes I don't want to feel the ground. Sometimes I want the cushioning. So it's interesting how it varies within the person and between people.
No, definitely. We had many runners in our trial and many just didn't enjoy them. The weight, the feel, it's very specific to what people are comfortable with.
Yeah. So what are some of the things you measured in your trial? Bear in mind that the results haven't been published yet. The protocol is published. That's really interesting. I'll put that in the show notes for people to have a look at so they can watch this space for the publication. So you're looking at, do you want to tell us what the aims were and what you what you're measuring there?
Yeah, definitely. Well, first off, we compared heel lifts to a sham, and the purpose was to see how if the heel lifts had a specific treatment effect or if it was mostly contextual factors or placebo. And we use a flat cushioned insole compared to a heel lift. And we also assess the biomechanics to try and understand if the heel lifts changed Achilles tendon load and worked the way we think they did. But the main outcome was pain. Pain intensity that's worse than the past week, because that is why people come to clinic to try and improve their pain.
So we're going to see if that pain improves, and that has flow-on effects for people's confidence and fear of movement and physical activity and willingness to load the muscle and rehab and everything else. So that'll be really interesting. So I'm assuming blinding was an important part of the efficacy of the sham or the validity of it. So how'd you go about, I guess this is ongoing if you don't want to talk about has the data collection concluded now for this study?
Everything's finished. It's being submitted for publication, and everything's been completed.
Oh, good luck. Well, we won't foreshadow the results then, but in terms of the methods, which are all in the protocol anyway, how do you go about ensuring people are feeling that they have an equal intervention in both groups?
Yeah, it's difficult. First off, it's impossible to blind the person giving the treatment because anyone with any background in health will understand that a heel lift and a flat cushioned insert are very different types of treatments.
Yeah.
But in terms of blinding the participants, it's the best way we approached it was to not mention heel lifts or sham. We just mentioned we were comparing two different types of shoe inserts. And then with the sham, we branded it with Monash logos and tried to present it as professionally as possible.
Yeah, and it's one of those things that you have to. It's brave, isn't it? You have to get onto the edge of understanding and possibility when you do research. You have to give it a go and see if it works. So you've done a really good job there. Tell us a bit more about the trial, because there was the biomechanical assessment in a subgroup. So 40 of the people did a biomechanical assessment. By the way, that's quite a lot of biomechanics. For those who haven't been involved directly in a biomechanical study, each person really takes a day, would you say, in terms of meeting and greeting, booking them in, reflective markers, everything else you used. Takes forever. And then there's the processing of all of that data. So once you get beyond 30 or so people, that's a big biomechanical study. So congratulations on that effort. Tell us about that part of it.
Yeah, the biomechanics was a huge part of the trial. After the participants were randomized to a group, they were taken into a biomechanical lab. They were set up with markers, inertial measurement units, which are little trackers to track acceleration, which were on their tibia or shin. And also they ran on a ground reaction force treadmill. So we're able to capture kinetic data. And from that, we can estimate our outcomes, which were Achilles force, ankle joint moments, ground reaction force, ankle plantar flexion and dorsiflexion, and tibial acceleration. And from that, we can estimate if the heel lifts change the biomechanics compared to the sham.
So few studies have done this in clinical populations, let alone in Achilles tendinopathy populations. And like I said, even fewer have looked at that that estimation of Achilles force. That's a biomechanical model that you do, isn't it? That you would have had help from your collaborators. So it's not a direct measurement of the Achilles force, but you're using all that data from 3D motion analysis, the units, so the inertial measurement units. Did you have EMG as well, or did you mention?
No, we didn't have EMG, and you're right. It wasn't a direct measurement, unfortunately, unless you have a sensor in the tendon. It's all estimates. There's also shear wave with ultrasound, but it's not. It wasn't feasible to have people running with it attached because it will just fall off.
Yeah.
But our measurements were based off the estimation of the plantar flexion moment, which is derived from ground reaction force, and a fixed moment arm, which is a population-based average. And from that, we get an estimate. But it is the best option for what's available at the moment.
Yeah, and to do it in running, as you mentioned, a dynamic task presents with challenges as well. And I imagine this is one of the first times that it's been done in this group of people. So that'll be really interesting to see what the forces are with and without the heel raise, because as you said, there's just very little data on this, but it's really commonly done. People have a heel raise for a variable amount of time and we don't know much about it. So here you are on the frontier of discovering new knowledge. It's really good. I'm deliberately asking these questions in a, kind of broad way, just to make them, rather than diving into the specifics of your biomechanics. What else can you tell us from a clinician's point of view? What would be interesting for us from this biomechanical part of the study?
Yeah, well, just to, as you mentioned, it's new. This is the first ever study on heel lifts or these outcomes in people with Achilles tendinopathy. So the rest have just been on healthy people, which is difficult to use for people with an injury. And clinically, I think the interesting parts of the study was the magnitude of force that goes through the Achilles tendon in terms of giving perspective for rehab in how in the dosage of what strength and conditioning and perhaps someone like an elite runner might need versus someone who walks around the house. Because as we know, the Achilles can absorb significant load and the strength and conditioning needs to be prescribed accordingly.
And we should talk about who the people were. So they had mid-portion Achilles tendinopathy for at least 6 weeks with a severity of pain at least 3 out of 10, regularly using footwear that can accommodate heel lifts. So that's important, the ecological validity of it. They're in their normal footwear that doesn't feel too different to them. And who were they in terms of their athletic level? Were they all runners?
They weren't. There was many that weren't runners. They were just volunteers that were happy to participate.
And they could run, people who could run on a treadmill but weren't a full-time runner, for example.
Yeah, no, most of them were, I would say, just people who might play occasional sport or are typically walkers but tried running. So I felt very much reflective of the people we see in clinic that aren't always elite runners, but just everyday people with Achilles tendinopathy.
Well, that's important, isn't it? Because you're a clinician first and you're seeing these people in the clinic and you're thinking, well, how do I help? How do I contribute to the research, the literature base for this condition? And now you've recruited a group of people who reflect the people you see in the clinic. So that's that external validity again is really important. Yeah, great. Well, look, there's not too much we can go into. Is there anything else we can talk about, but without spoiling upcoming publications and presentations? Anything else that you think clinicians would be interested in?
Well, we also recently published the Delphi guidelines for Achilles tendinopathy, or I was a part of. That was a project run by Peter, and that's a very useful clinician tool to diagnose both mid-portion and insertional. And I'm sure Luke can put that description in the show notes.
Well, that one's hot off the press and available online. It's in British Journal of Sports Medicine. So as you mentioned, Professor Peter Malliaris was the lead author, and Professor Bill Vincenzino, senior author, and many other people, including yourself, contributing to that consensus statement. And I can put that in the notes for people, but that's a good one. If you're interested in this field, you should be having a look at it. So the aim was to define the consensus on diagnostic domains and differential diagnoses and conditions that require further medical attention. So if you're, say you're a new grad and you're just starting out, you're thinking about, okay, I think I've got my head around the diagnostic criteria for this condition. What else could it be? So the differential diagnoses, you can refer to a paper like this, which is drawing on expert opinion and summarising it, as opposed to a systematic review, which you did, Jaryd, which was, and there's many systematic reviews published, which look at peer-reviewed evidence and summarise their findings and perhaps try to draw together quantitatively into a meta-analysis. So it's a different study design for practitioners to be aware of and have a look at. So what was that like being a part of that? You got to meet a few stars of the tendinopathy world?
My part was very much writing and summarizing the outcomes. So not too many. I didn't meet too many of the stars.
Well, that's all to come, no doubt. Yeah. But really good to be a part of a team like that, no doubt. So that's good. And that's probably the reason it's good to mention that is for those considering a research degree or research career, or for those who want to be a practitioner but want to get involved in research. Just get involved for the first time in research. Have conversations with people like Jaryd and myself. I'm always open to those conversations, but you can ask questions. How did you first get involved in this? And why don't I ask you that, Jaryd? How did you first get involved in research? You were fairly fresh after graduating compared to me when I first got involved in research, but how did it start?
Well, I did Peter's Mastering Lower Limb Tendinopathy course, and I sent him an email asking him some questions, and he said, if you ever want to come to Melbourne and meet at Monash, happy to show you, but he'd try and convince me to do a PhD. And during COVID, I had not very little to do, so I emailed him, and it went from there.
So you can blame COVID lockdowns for your PhD. Wonder who else is in that category. That's good. Well, it's pretty interesting. We've got more to talk about once your trial's published. Any final thoughts? Any final messages? Or do we just wait and see what you publish?
I think if you're interested in research, definitely contact someone to give it a go. It's not for everyone, but it's very rewarding if it's for you. And I'll have to come back and tell you the results. Yeah,
for sure. We can do that. Now, it's a good final message. If you are, there's various levels of being involved in research. You really don't have to. Well, as you said, it's not for everyone. Doing a PhD or a master's by research is not for everyone, financially and in terms of your interests. But some people it is. And it's hard to find information online about it, to be honest. You've got general information about how to enroll, but in terms of cultivating your interests and building your networks, really just do what Jaryd did. And if you're interested in an area, just email someone or buy them a coffee and have a chat to them, because a lot of this information will come from conversations and the long lost art of conversation. I guess this is what we're doing here on the podcast, but build those networks up and talk to people, ask them questions. So that's a good final message. Well, Thanks very much, Jaryd. We'll come back and do it again and find out what the results are, but some good messages for now for our clinical practice.
Thanks, Luke.
So everyone, if you found that interesting, share it with a friend. Don't do too much call to action these days. You know what to do. Like and subscribe and all that stuff. But do stay tuned for part 2 of the conversation in the future. And you can follow Jaryd's work on Google Scholar. You can follow him on LinkedIn if you like. He's got a profile I'll have in the show notes. And we'll have links to those articles there in the show notes as well. So thanks very much, Jaryd. And until next time, this is Jaryd and Luke wishing you all the very best with your studying, professional development and lifelong learning.